Good evening. I'm Julie Evans. I'm the Executive Director with Roots and Roads Community Hospice Foundation, and I want to welcome you to our 2022 educational series, Mortal Curiosity. We have an event the third Thursday of each month from 6 to 7, sometimes lighthearted, sometimes very pulling out the heartstrings, and glad to invite people from whatever perspective they're coming at, whatever comfort level they have with talking about end of life. And that's really our hope, is that people become more comfortable talking about, learning about, and exploring end of life. Because of course, it's the one thing that all of us will share in common. Some of us, don't have to pay taxes or don't pay taxes, but all of us will die someday. So welcome. And I'm going to just go through a couple of controls. So, right now, everybody, as I mentioned, is muted. So you won't be able to talk until it comes to the Q&A part. But should you decide that you want to be on screen, and we love to see you, you'll see this little video icon. Just click that, or alternatively, if you have to step away for whatever reason and you want to turn it off, just click on there. If you think of something while Ann's talking and you're afraid you're going to forget it, you can put it right into this comment, this chat box here, and then that will kind of keep a rolling log of folks' questions. But of course, again, you will be able to interact directly with Ann and David, our moderator, once Ann is done presenting. And then up here at the top, moving everybody around, where it says view, you can change how you see the screen. So if you just really want to see Ann, you could do that speaker view. Right now, we're in gallery view, where we can all see each other in equal sizes. And of course, I'm sharing my screen for this PowerPoint. But okay, so that is sort of the business end of things. And I am going to turn the mic over to Mr. David Fife, our Director of Community Engagement. David?
Thanks so much, Julie. We are so grateful that you all are with us tonight. To begin, I just want to talk a little bit about Roots and Roads Community Hospice Foundation. From the slide, you can see that our vision is to transform the end-of-life experience into the final act of living well. And we do that through 3 different areas. I don't know, Julie, if you want to go back real quick.
Oh, I'm sorry about that. I was trying to move everybody around on my screen.
But there's 3 areas that we focus on. The first is that we provide financial support to hospice patients and their loved ones when they're not able to make ends meet. So it can be everything from helping with housing costs and utilities to safety equipment like bed alarms. Sometimes it's helping folks have a loved one travel from out of state in order to be able to say goodbye. And then we also focus on community education, like this event tonight. But we have this series throughout the year on many different topics. And then we also provide community education around advanced directives and education around hospice and palliative care. And the last area is that when there are innovative initiatives for end-of-life care that we in the community, we seek ways that we might be able to support those initiatives as well. You want to go ahead, Julie? This slide will just give you a little bit of a picture of what we worked on last year, areas that we tried to serve the community. The education, patient fund requests, but I also wanted to highlight hospices will seek to honor veterans that are on service. And that will look at, they have different ceremonies and gifts that they're able to offer as ways of thanking veterans for their service to whatever branch of the military, but then to all of us as well. It means a great deal to veterans to be recognized in this way. And so we find ways of supporting each hospice in those efforts. All right. And tonight, we are so grateful to have Ann Neumann with us. She's the author of The Good Death, an exploration of dying in America. It's an amazing piece that offers compassionate and honest perspectives at death and dying in America, and I highly recommend it to you. You can see from her bio on your screen that Ann's voice and perspectives are vital to our conversations about end-of-life issues. She combines skills as a researcher, a teacher, writer, and hospice volunteer to help us better understand the ecosystem of serious illness and end-of-life care. So we are so honored to have Ann with us, and we're going to turn it over to you now so you can begin.
That's great. Thank you, David. I think the honor is definitely mine. I also want to thank Jennifer and Julie for putting all this together. And thanks to all of you for being here tonight. It's an evening. These are strange times, and I very much appreciate the attention that you're giving to this topic. I think that we're all aware of the fact that nursing home residents suffered more during COVID than any other population in our country. The loss of life was enormous. According to AARP and Kaiser Family Foundation, more than 200,000 people, residents of nursing homes died. And of course, we know that those numbers, and I know from my reporting, as I'll get into further throughout this evening, we know that that reporting is completely inadequate. Many facilities were sending residents at the first sign of symptoms to the hospital, and those deaths are not counted. There is also, there are incidents of undercounting as well. But at the beginning of the pandemic, nursing home residents made up 50% of all deaths in the United States. And even still, nursing home deaths account for 23% of all COVID deaths in the United States. So this population was devastated. And so now we're looking at an industry that has long been in crisis, and that is even deeper in crisis. And we can get into some of that in a bit. But what I want to do tonight right now is tell you why those deaths were absolutely unnecessary. And I want to do that by taking you through my own process, my own experience of nursing homes. Thank you for that great introduction, David. I have spent a lot of time writing about end-of-life care, and elder issues. I haven't spent a lot of time writing about nursing homes. And it's really because I was reticent to jump into the whole chaos that is Medicare and Medicaid. And you really can't discuss nursing home care without looking at those systems and that history. And so I had not written about nursing homes. And I had an editor contact me in the fall of 2019. And as you know, that's the fall before the pandemic began. And I finally agreed. She had asked me about 6 months earlier to write a piece about nursing homes. And I was like, nah, not my thing. And when she came back again, I was like, okay, let me figure the system out. And so in the fall of 2019, I said, I want to do this. I want to go to Philadelphia to do this work and look at nursing homes there. Philadelphia has one of the oldest largest low-income elder populations in the country. Philadelphia is also in my home state. And so I felt a greater familiarity with the politics there. But it's also a state where two senators came together in 2018 and 2019 and put pressure on the Centers for Medicare and Medicaid Services, otherwise known as CMS, to release data on nursing homes. CMS had been sitting on a lot of this data. So nursing homes self-report data to CMS, and then CMS releases that data. Theoretically, they hadn't done so in a while. Bob Casey and Pat Toomey a Democrat and a Republican respectively, got together in the state of Pennsylvania and said, well, we have this data, CMS. If you're not going to release it publicly, we will. And they did so. So I decided, if I'm going to write this piece about nursing home care for The Guardian, I'm going to base it in Philadelphia, where all of these factors come together. But I want to ask us to think a bit about what we thought of nursing homes in 2019. Not so much, right? I don't know, as a hospice volunteer, how many times I heard people say, there was no way I was going to a nursing home, or I'd rather die than be in a nursing home. They don't smell good, the food's terrible. Everyone, you know, you're not allowed to do what you want to do. They won't let you go out. You've got to stay in one of those beds. We've all known that nursing homes have had problems, but we thought they were cosmetic. And a lot of us don't discuss in our media, in our public life. We don't really discuss the challenges that that nursing homes face, but they are dire, and they have been for a long time. I was talking to a University of Chicago historian named Gabriel Winant. I was interviewing him for another piece on hospitals. And one of the things that he told me is that it's fair in some dimensions to see nursing homes as semi-carceral institutions. We also know that during the pandemic, reports came out about what I would call physical abuse. Patients who were given hydroxychloroquine and other experimental drugs during the pandemic, nursing homes who were trying to fight the number of deaths, who were desperate to save their reputation, and resorted to all sorts of unethical practices. So as I mentioned, in the fall of 2019, I was given this assignment to try and figure out what's taking place in nursing homes. I knew a little bit of information about them. I decided to base my research in Philadelphia. And what I want to do now is walk us through 6 perspectives that will give us 6 lenses, these different views on what's taking place in nursing homes before the pandemic, during the pandemic, and where we're at today. And so I'm going to start with the media. When I got this assignment in 4 months before the pandemic shocked us all into our homes, there was an article that I found that had established a media narrative. The New York Times Magazine ran a piece by Jack Healy in March of 2019. This piece was on the cover of the magazine. It was very prominent. It was very beautiful. It was also very romanticized, and it was very simplified. The title was "Nursing Homes Are Closing Across America, Scattering Residents." Now, Jack Healy identified a very serious problem. Nursing homes indeed are closing all across the United States. But what he failed to do was identify the real issue behind those closures. In fact, the cover photo of a woman holding a picture of her loved one is a woman who is in South Dakota, and her partner, husband of many years, was at Mobridge, South Dakota facility. And that facility was indeed closed, and her loved one was sent many miles away. And this is an issue that's taking place all across the country. Facilities are indeed closing. Jack Healy, throughout the piece, lets us know that this is a real problem. And he does so very convincingly. Editors across the United States were all of a sudden trying to assign stories about the closure of nursing homes. It was a very compelling piece. But when I sat down with it in the fall of 2019, I reverse reported it. And I looked at all of the people that Jack Healy had talked to, and never once in the article does he explain, and maybe he never discovered, that facilities on the most part, or for the most part, are closing not because Medicare and Medicaid payments are a little too low or because there aren't enough people filling these facilities. Facilities across the United States are both mostly closing because of fraud. Indeed, the Moe Bridge facility that he highlights in the piece was shut down because of fraud. And so that's when I was like, oh, I know exactly what I'm doing here now. So I found that the narrative that was compelling so many pieces across the country, and I don't know if you remember this, I don't know if you caught this, but there were a number that were examining this terrible closure of facilities. And for the most part, the reporters were talking to industry folks who were saying, well, we represent the operators of these facilities, and Medicare and Medicaid just need to pay us more money. That's the story, but it's not the real story. And what I did was drive to Philadelphia and talk to everyone I could involved in the nursing home industry to try and debunk exactly what Jack Healy had reported, to try and unstitch this narrative, to find out what was really taking place. I want to tell you a little bit about how Medicare and Medicaid do work, but I'm going to give you the Cliff Notes because it's very complicated. But in every state, a certain amount of money comes from the federal government and a certain amount of money comes from the state. Medicare is paying more for residents' care than Medicaid, and each individual resident gets a certain amount of hours. So that varies by state. Let's say it's 100 hours, right? If you get Medicare for 100 hours, when your Medicare is up, you're switched to Medicaid, and Medicaid pays less. And nursing homes don't want less money. And so what they have done over several decades is talk to consultants, do everything they possibly can to get as many Medicare residents in their facilities as possible and to minimize the number of Medicaid. So what we're finding, because of this structure that has developed over multiple decades, right? Medicare and Medicaid came in to cover this kind of care in the 1960s. And it's been kind of finagled and finessed ever since then. But what I found when I got to Philadelphia was that this kind of structure that there were three primary ways in which the nursing home industry was failing our residents. There were three primary problems. One was gross understaffing. Of course, if you are working really hard to make ends meet as an operator of a nursing home, the easiest way to cut down your budget is to cut down on labor. We see that at corporations across the country. It's just a primary feature of capitalism. And it is also indeed something that takes place in nursing facilities. Some states are better than others at policing staffing levels. But we've found that some facilities are quite happy to pay the fee that they are charged for being understaffed because it's still cheaper than fully staffing their facilities. Another issue that is rampant within the nursing home industry is fraud, as I mentioned. And I'll get to that in a little bit. But the advent of private equity, or the entry of private equity into nursing home operation, has been a real problem. And then the other issue that is kind of a compound of problems is the lack of state and federal oversight. For decades, anyone who's been watching the industry could tell you that there's not proper infection control in facilities, and it's certainly not, it's not regulated. But also, just as I mentioned, staffing and other problems persist. So those things have long existed within the nursing home industry. We didn't know that the crisis was coming. Editors were perpetuating a narrative that that Medicare and Medicaid need to save the nursing home industry. And then the pandemic hits. And we're seeing crazy numbers of death all across the country. And everyone that I talked to in Philadelphia had predicted this. They said, we're going to see a crisis of this sort. And they, from industry watchdogs to ombudsmen who represent facilities, who represent residents in facilities. So that's the media lens. We've got this narrative. We're not prepared for what's coming at us. Operators, as I mentioned, are another fantastic lens to think about what's taking place in the industry. Like funeral homes, right? Nursing homes were once the family business, or they were run by religious entities. And over the past several decades, that has changed. And private equity, or the operation of strings of facilities across states, has taken place. Multiple corporate names have been used. I researched one facility in Philadelphia that was also the operator of the facility in Mobridge, South Dakota, named Skyline. And they had, in the course of 2 years, they had acquired 100 facilities all across the country. And in the course of a few days, they abandoned them, and staff members were paying food vendors. They just disappeared. What private equity has been doing, in addition to buying up these, strings of facilities, is selling the real estate out from under properties, collecting the rent from operators. So they're separating the resources in these facilities. Also, many states don't vet buyers of nursing homes. They simply don't have the power to investigate any of these shell games or shell names. And so the operators are a huge problem. They're sucking any resource out of facilities and moving on. The nursing home industry has one tool in its toolbox, a way for advocating for residents. And those advocates are called ombudsmen. When the program was set up, those ombudsmen were established, and they are contracted out to state entities in each state. But in Philadelphia, the organization that I talked to is the Center for Advocacy for the Rights and Interests of the Elderly, or CARI. And I was able to work with CARI to visit different facilities and learn more about their work. What they found was that they didn't have any teeth, right? They spent most of their time fielding concerns from residents and residents' families. They were concerned about various issues like bed bouncing, a problem within the industry of individuals being checked out if they were running out of Medicare, the higher paying Medicare, Medicaid funds, or checked into hospitals if they were found to be a little too demanding. And the ombudsman found that they didn't have a way to really hold these facilities accountable. They could report problems. They could do a lot of negotiating between residents and families and facilities. But in many states, they don't have any way to hold operators accountable. There's one woman named Jessica Hartfield who worked with a facility of disabled adults. And I was able to sit in with this group. They called themselves the peers, and they were advocating to raise the allowance that they receive from the government on a monthly basis. They told me stories of trying to save up their money to buy a sweater. The allowance was so low. After the pandemic hit several months later, I stayed in touch with Jessica, And indeed, half the group did not survive COVID. I talked to Jessica just a few months ago, probably like 6 weeks ago. I was working on a piece for the Cambridge Handbook on the Anthropology of Death. And I asked Jessica what she thought about the many deaths that occurred during the pandemic. And she said, I'm trying not to get choked up, because the unfortunate truth is that many of those deaths could have been prevented. The residents have been incredibly vocal. I just mentioned the peer group, but there's an individual I met in New Jersey. His name is Glenn Osborne, and he is the president of the Residents Association. He is at Menlo Park Veterans Memorial Home, and it is the home in the United States that lost more residents than any other. 100 people, or roughly half the residents at Menlo Park, died. Paramus is the other facility that you probably heard a lot about during the pandemic. But Glenn felt it his mission to document everything that he saw taking place within the facility, and writing letters to every one of his representatives. At some point, a lawyer tracked him down, and we'll get to lawyers and the role that they've played in taking care of residents during the pandemic in a moment. But I could tell you many stories about Glenn. I've been to see him twice now. The facility has Operation Rocking Chair, which is their program where you can meet people outside 6 feet apart, wearing masks, and at least talk. They've since changed their policies, but they meet outside as much as possible now. I have watched Glenn go through this crisis with wonder. He is tenacious and tireless. I've attended protests by staff members and family members outside the facility. What we found at Menlo Park is that staff were also dying and were quite motivated to voice how helpless they felt in the wake of COVID to help their patients. Decisions were being made at the top, and they wanted to work together with residents to raise awareness for what was happening inside. They tracked down a lawyer named Paul DaCosta, who saw all of the laws that were being passed across the country, immunity laws to protect the responsibility of any of these facilities. And Paul said, I can work with this. He worked with Glenn, the resident at Menlo Park, and collected as many stories as possible from residents and family members. Glenn had mapped the movement of residents throughout the facility by management during the pandemic. And along with other residents, they were able to put together a story that that skirted the immunity law in New Jersey. And about 2 months ago, Paul and other lawyers were able to win a $53 million lawsuit on behalf of 100 families at Menlo Park and Paramus. He was able to do that because the immunity laws carved out exceptions for cases of gross negligence or cases of reckless and willful conduct. So through collecting the stories from Glenn and other residents, he was able to accumulate serious proof that reckless and willful conduct had taken place. I talked to Paul, like I said, a couple of weeks ago, and he said that as soon as that was the lawsuit, the settlement was announced, he was inundated by family members of nursing home residents across New Jersey. And so I think that the success of this case will cause other cases to be brought to bear around the country, particularly because these immunity laws were passed so quickly and many of them look alike. They were passed in 34 different states in my last count. I mentioned staff earlier. We often talk about the tragedy that residents experienced, but there were staff members who were also going through this inside facilities. And I have a special place in my heart for the individuals, predominantly women of color, quite often women from the Caribbean who do hospice work and this nursing home work. And we have to acknowledge the discrimination that they receive as women in workplaces, as women whose wages are depressed because they're women or people of color. And at the beginning of the pandemic, same editor at The Guardian said, why don't you talk to nursing home staff around the country and tell me what their experience is? And if you remember, at the very beginning, we didn't know how this thing worked, right? We didn't understand this virus. We thought that maybe it was on surfaces. We didn't know how it was spread to others. We were very afraid of sharing it with our loved ones. And so I tracked down people from Colorado to Pennsylvania and talked to them at the very beginning of the pandemic about what they were doing to keep their loved ones safe. That was really the thrust of my questioning. And I talked to, I don't know, dozens of women. And the little piece that came out in The Guardian was a reduction of our full conversations. But for the most part, these women were scared to death. On the average, nursing home staff make about $19,000 a year. It's really hard to get by on one job. Many of them don't have health care, and quite often they're undocumented. And so this group of people, they told me that they were wearing multiple layers of clothes. They were taking off the outer layers when they left their facilities. They were wiping down their homes. They were living segregated from their family so that they wouldn't share it with their family members, but also individuals who are working multiple jobs have been targeted by some as the cause of spreading COVID from nursing home to nursing home. So these are structural problems, right? These are individuals who are vulnerable because of the disrespect and the low income nature of what they're doing. I had the opportunity to call all of these women just about 6 weeks ago for a piece I was working on. And I asked them how they were doing and how they had come through things. And Mary Walker is one woman who appeared in the Guardian piece. She had worked at Inglenook at Brighton, in Brighton, Colorado. She told me that in her facility alone, 80 people had died. She no longer worked there. She told me that she couldn't take it anymore, that she had realized that that the deaths of her residents was no longer affecting her, and that was alarming. She now works at a small group home. And when I said, were these deaths preventable? She said, yes, absolutely. There was no reason why we couldn't have PPE, that we couldn't have taken the proper precautions, that we couldn't have had more staff. I also talked to a woman named Julie Moore in Philadelphia, who was so moved by the pandemic that she got involved in the labor union and was doing organizing for SEIU 1199. She found that her love of her residents and their deaths was so traumatizing that she wanted to do something, and changing the way that staffing was managed in these facilities was her thing. her facility lost 70% of staff and residents. And that's the other thing that we don't discuss, right? We're not counting the number of staff who died because of pandemic inside the facilities. And she said to me, "I'm not God, but I think those deaths, a lot of those deaths could have been prevented." So I think that some of the lessons that we've learned from the pandemic in the nursing home industry only reinforce the lessons, the issues that we had before the pandemic struck. We knew that these facilities were understaffed. We knew that fraud was a case, that people were buying and selling nursing homes like used cars without concern for the residents on the inside, without concern for staffing. We knew that states were not paying attention to that buying and selling or to the understaffing or even to infection control and other issues within facilities. So the pandemic has really only reinforced in the grimmest way. It has told us that the lessons that we should have learned before were paid for in lives. And I think that we're coming up on time, so I don't want to run this too far, but I hope that some of your questions will involve maybe greater issues of autonomy for residents, but also what the future could look like for nursing homes and what we anticipate it will look like. Because I think, sadly, because denial is such a huge part of our experience of the pandemic, I'm not seeing enough motivation to change things. So thank you so much for your time and for the opportunity to share this little slice of my experience of the pandemic in nursing homes.
Thank you so much, Ann. And I think, Julie, is this right, that that people can just unmute themselves and go ahead and ask whatever questions you might have. And as people prepare to do that, and could you maybe just explain a little bit more that role of the ombudsman and what it's charged with? And then I understand you made it clear that the teeth is not behind that, but what's their charge?
Yeah, they are to advocate for residents' rights and well-being. And every nursing home that you're in, it is required by law that the ombuds person is listed, their contact information is there. And still a lot of residents don't understand that this person is available for their phone call at any time. I think in some states they have more leverage, but for the most part, they mediate between residents and family members and facilities, but they're incredibly knowledgeable about what's going on inside facilities and what rights residents do and don't have. And I can talk a bit more about that if you have specific questions.
My question is, what role did vaccination play in the process? That was introduced a couple of years ago, and I would have thought there would be improvement after vaccination.
Yes, indeed, there was improvement after vaccination. What's your name again, sir?
All right, Ed Fix.
Hi, Ed Fix. It's nice to meet you. Thanks for being here tonight. Yes, indeed, vaccinations were introduced as soon as possible, right? Elders were the first group to receive them once they were available and approved. And I just looked at the map today. There are about 5 states that have less than 60% of their nursing home residents vaccinated. And I recommend that you all go to the AARP website because it's, I mean, we all know AARP started out to hawk insurance, right? But this organization has grown and it's got so much reach and so much financial power. The data that they're doing now on nursing homes is probably the best in the country. They've been on it and they've been wonderful. Another great resource is, like I mentioned earlier, Kaiser Family Foundation. So only 5 states have less than 60% of their nursing home residents vaccinated. Every other state has more. So indeed, vaccines have helped. And I know that they're just a good relief for all of us. As well, we have learned a lot about how this virus operates. We know that cleaning surfaces is great, but it's not going to. We can't get the virus from surfaces anymore. So all of that knowledge has been incredibly helpful. However, facilities that work on such a small margin have lost a huge percentage of their residents. And so we're not quite sure how they're going to move forward. Thanks, it was a great question.
David, can I chime in? Hi, I'm Kevin Carmichael. I'm a physician working in HIV and AIDS for most of my career. So I've had issues with nursing homes since the early days when I couldn't find a nursing home in the city I work in to take care of people with HIV and AIDS, and only found one that we spent a lot of time, working with and soliciting and all that. Subsequent to that, I had both of my parents ended up needing some long-term care at the end of near the end of their lives. And of the difficulties. But I'm curious if you see any light at the end of the tunnel, because these days, even though COVID seems to be perhaps lightening a little bit, there seems to be enough other dark things around. But where do you see the future of nursing homes? It seems, I'm wondering sort of where, is there a place we can put efforts to rectify the situation? Because I mean, I'm hopefully going to die before I ever need a nursing home, but the odds are not good. I mean, the reality is I may need to be in a nursing home.
Right. In Pennsylvania, what the efforts are now is to put a lot of money, the resources that are going into nursing homes, to put it into home care. And as soon as we're talking about home care, we're kind of on my home turf. Like 80% of us want to die at home. This is why the home hospice program is so great, although it's grossly underutilized. So I think if we put all our eggs in that home care basket, we're not going to be serving those individuals who don't have homes or don't have individuals to care for us. Because even if we do subsidize home care, at the moment, Medicare only covers, 4 to 10 hours. If you've got an incontinent patient, that's just not going to cut it. So even if we do beef up our home care allocations, we're never going to be done with nursing homes. We're always going to need them. And I think more than anything, we just need to do it better. We know that family-run facilities could pull it off. We know that we need to increase Medicare and Medicaid, but we just aren't doing what's necessary to watch these facilities, to make them accountable, to make sure that they're properly staffed. And we're very good at policing other facilities. We're very good at this as a country, right? We can hold facilities accountable to good practice. We're just not doing it right now.
So just in my naivete, is there not-for-profit nursing homes out there? Because certainly in both the hospice arena, where I have spent some time working, and in multiple arenas, what we're seeing is just the industrialization of everything. And you talked about venture capitalists and stuff like that, and the churning of the squeezing for maximum profit and all that. And in my work, I've always taken care of people that had relatively limited resources, but we always made a living doing it. So,
right.
So that's, I guess my question is anyone looking into that model as a different way to go?
I mean, nursing homes, for the most part, throughout history, have been nonprofit, right? It's really only in the past several decades that we're seeing this turn toward for-profit entities. And You know, again, coming from the hospice world, I love the idea that altruism and medicine should be nonprofit. But we're also seeing a lot of hospitals that make a lot of money as nonprofit entities, right? So I think that also has to be regulated as well. I also just want to commend you for doing work on HIV and AIDS, because you come from a realm where you understand stigma. And I think that our elders very much experience that kind of stigma in our healthcare system, as do the poor, as do people of color, as do, you know, nurses and staff of color. So so you probably have a number of lessons for us.
Yeah, lots of things I've learned, but not sure how to act on them all the time.
Yeah, thank you.
And I just going back to the point about the oversight, I'm curious what your thoughts are on why there is such lax oversight. David and I were just talking about this earlier today around the hospice piece, but yeah, we're really great at policing certain things, but do you think it's industry pressure? What's your guess about that, or what has your research revealed about that?
There's this amazing woman named Toby Edelstein. She keeps a newsletter, a monthly newsletter. I can share it with you guys later. I can find her. And I think she's like Medicare and Medicaid Advocacy or something like that is the name of the organization. But what she has said is that when a lot of these fraud cases have taken place, some states have been reticent to step up and fund and support those facilities until they could find a buyer. And that one story, and there I could take you into specific cases, but I won't. But that made me realize that states don't want to be in the business of doing this care. They also don't want to be in the business of overseeing it. It's not something they're familiar with. They don't have experts on hand. They just, I think, compounded by I just said stigma, but I'll say it again, the stigma of elder care, compounded by, I don't know, a lack of knowledge about how to provide quality long-term care to elders. States have just been reticent to get involved. You know, and this is a side issue when you consider that we have a healthcare system that is really inadequate, that is crumbling in many ways. Just look at mental health care right now. So this population, I think, has, it's not first priority, it's not even second priority. And we have a system that from top to bottom is in crisis in many ways.
And just to, Alan, you can go next, but I just want to let everybody know is if you prefer not to speak up and ask your question, you can go ahead and put it in the chat box and we'll follow up with that. So go ahead, Alan.
Ann, I'm Alan Baruther, and I'm the one that sort of contacted you, and I'm glad you were able to show up for our virtual meeting.
Well, it's nice to see you, Alan. Thanks for having me.
And one of the things I just wanted to bring up, I think I caught it in the news, but there's so much coming in the form of bills and such, but there is a renewed effort to try to get training, in-home care training for relatives, formal training, and provide stipends for those people to keep relatives in home with relatives and loved ones taking care of them. And I think there was a renewed effort to do this. And I know in some places, maybe at the state level, they do it, but I think it was on a federal basis, they were trying to renew those efforts again, which I think many people would like to be able to do if they had the training, if they had the hospital beds and the facilities to do it in home, to keep that relative home and not go to a hospital. I mean, go to a nursing home.
Right. I've heard this too, Alan, and I'm glad you bring it up. I think that there were a number of things that this administration has said. And while that sometimes, you know, puts fire under an initiative, we haven't seen that fire yet on this, as far as I know. But I do think training for individuals who are caregivers to family members would be fantastic. But I also would just love to see paying people to take care of their elders. It's a huge problem where individuals are, I quit my job to go home and take care of my dad when he was dying. And that was, that's a hardship. And we see this in families all over the country. So I would love to see training. I would love to see just support, financial support for those individuals. And I think that that is a great way to take the burden off of the nursing home industry or the long-term care industry. I should clarify, nursing homes are just one type of facility within a suite of long-term care facilities in the country, and they all have their own specific regulations. But I do think that we could take the burden off of long-term care if we started resituating our care to the home. I don't think that's going to ever make nursing homes or long-term care unnecessary.
There was an article that came out in the news today that said that Humana sold a majority share of its hospice and home care division to a private equity firm. And that's been the trend, not just in hospice and palliative care, but in healthcare generally. And you alluded to that in terms of the chains of care facilities that will be regional or maybe even national for that is, so it seems like that's the direction we're going in. It's not, it's that there is profit to be made within that kind of a context and a large scale. But most of the things that you alluded to in terms of solutions were much more community-based, smaller, and responsive to the community that folks were living in. And so it's this movement going one direction with a clear direction for improvement in the opposite. And I don't know, have you seen any local efforts that have been successful in being able to provide that kind of quality care that bucks that kind of trend?
Oh, absolutely. I mean, that's the traditional family-run nursing home is really the way to go. If you look at the ratings of facilities across the country, you can look at the CMS listed rating on any facility, and you can tell the ones that are private equity. They're like 1 star. They just aren't delivering the quality care, and they don't care about it. They don't care that they're not doing so. It's quite easy for these large scale facilities to pay fines and to go about their business because they're making their money. And I don't think that states have determined any way to make them provide what they should. Like if there's a facility that's getting fined because it's chronically understaffed, the facility, it's still cheaper than them hiring to staff quotas. So we just don't have any way to hold these institutions accountable. The other thing is that they change names all the time, right? Like, so you'll find one owner is the CEO of one and he's in 4 states, but his brother-in-law is the CEO of the sister company in 7 states. And it's very hard to track them down. That would be an entire project just to track these entities. And I mean, tracking their financials would be difficult. So long answer to your question, but yes, these are the facilities you should seek out for your loved ones who are going into long-term care. The family run, the little places, they do still exist, but not very many of them.
Mm-hmm. And so if someone is looking for the rating for Medicare and CMS, they can go to the CMS government website And then they can look in terms of skilled nursing facilities and the area and then see the ratings. Is that how people would do that?
Yes, absolutely. Yeah, SNFs are all listed, skilled nursing facilities, ratings is, they're very public. This is what I was talking about at the beginning, where CMS hadn't released that data for a while. And Bob Casey and Toomey were like, well, okay, we're going to release it. CMS has been better about it. But again, that data is all self-reported, I remind you.
Yeah.
So the quality of that data is always in question. I would say if you have a loved one who's going into a facility, find family-owned places, nonprofit, and then talk to the ombudsman in your region, because that's how they're assigned. They're assigned regionally. So I cover, I don't know, this township, right? And the facilities in this area. So talk to the ombuds person, and they will be able to give you better direction.
David, could I chime in again? I don't want to get in the way if someone else is waiting.
Come
Go
on.
right ahead, Kevin. That's great.
Yeah, hi, it's Kevin Carmichael again. I'm sorry, I turned off my camera. The other thing I think that's important is all those things you said are great, but I also think we need to have like a class for families who are getting a loved one into a nursing home. Because I mean, a video series just, and one of the things that I think is really key is how you as the family relate to the facility, and particularly the people there. I mean, again, I'm a physician, but when my mother was in a facility, I went every Monday, Wednesday, Friday, and then on Saturday and Sunday, I would go and visit, and I would take coffee for the nursing staff. I'd ask about their kids and all that stuff, just to get them to care about my mother, who unfortunately was quite challenging to care for. The other thing is there's this expectation of perfection that you're not going to find in any nursing home. And so my mother, they'd call and say, your mother has a skin tear, and I would be darn, but I didn't call the boss, and I didn't file a complaint because I mean, my mother's skin was very fragile. I could give her a skin tear just trying to help her, out of a chair or into a chair or something like that. So I think it's a dance that you have to do, and I think that sometimes people feel so guilty if they can't no longer care for someone at home, then they expect perfection, and then they end up in this adversarial relationship that never works out. Just a thought.
I think you're making great points, Kevin, and I'm glad you brought them up. I think one of the challenges is that individual families don't prepare for this moment. It's very hard to know where to start. These are difficult subjects to discuss. They're socially taboo in many ways. And so individuals find that their grandma falls, she breaks her hip, she comes out of the hospital, and they put her into rehab in a nursing home. And rehab is paying really well. The nursing home wants to keep her until that rehab higher payment runs out and she's moving on to Medicaid. And then they're going to bounce her. They're going to, try to keep that bed for the higher fee. Families don't know what their rights are. They haven't had this conversation with grandma about what she wants, where she wants to be. The system is by design opaque and difficult to negotiate, and I think facilities benefit from that, particularly the predatory ones. So we have to do a better job of preparing ourselves. Just how many of you here do not have an advance directive or a living will? How many of you haven't had this conversation with your family? The very first thing that we can do tonight is commit to each other that we're going to have these conversations with our loved ones. And hopefully that will spur them to do the same. Because when we go into these situations unprepared, we find that care is never at the quality that it should be.
Amen.
Oh,
Amen.
yeah, I'm
So
looking.
did you see that from LaDawn?
Yes.
In the chat? She's a social gerontologist, and I have to tell you, a real gift to this whole community. But she's having tech issues. Do you want to read it?
I would. Great presentation. Thank you. As a social gerontologist and someone who has been a volunteer ombudsman, I'm super excited for your work. I'm having tech issues. What are your thoughts on tying quality and patient satisfaction to facility reimbursement? I don't think that happens in long-term care like it does in hospital or acute care. I also, I think that it's greatly challenging in that kind of system, because we know that elders may not be mentally or physically sound. I've had a lot of really crotchety hospice patients. They're in tough situations. But I don't want to blame patients for that not working. I'll have to think more about it. Patient satisfaction to facility reimbursement. I mean, it gets more complicated, right? I always think that the system is already so complicated. How would we structure it?
I think that's an issue when in hospice, the satisfaction surveys that are sent out, that'll go to the primary caregiver, right? So if someone's been in a skilled nursing facility, that oftentimes will happen where the family, who's the primary caregiver, may not even be in the same state and not having much interaction with those caregivers who, whether it's from the hospice or from the skilled nursing facility, yet they're the ones that are filling out the survey. So it's really hard. There's a disconnect that can happen as well. So that would be I imagine that would other added layers of challenge to that.
Yeah, added layers of challenge, right? I'd be interested in seeing the specifics of the models where that's being used right now. I'd be curious how that money is negotiated, how the two are tied. But it's a great question. And anything that focuses on quality of care is super important right now. How do we get more people to care about this issue? And I think when you say like me, you mean journalists, right? Sadly, part of the challenge is that young people run media at the moment, maybe always have in some ways. As a society, we don't value issues of elders. I had a conversation with Julie and David before you all got here, and we were talking about what it's been like to write about these issues. And I found some ways of appealing to editors' curiosity, some stories that you can kind of tuck in elder issues. And one was a Harper's piece I did in 2019 about a pattern of elder couples across the country who are choosing to end their lives together. And it's everything across the spectrum from Romeo and Juliet to the literal definition of domestic violence, the way that these deaths are taking place. And so I was able to have a conversation about poor quality of care and what it's like to do home caregiving within that discussion. But that was a novel situation, right? That's a novel issue. And so it was an easier sell with editors. And I think the David Healy piece that I have, or the Jack Healy piece that I have torn apart and been so angry about, that appealed because it was kind of a Midwestern romance. We love the Midwest. these stories of elders, you know, the old folks at home and the great longing of separation. But it was also a simplified narrative that really didn't get to the heart of the problem. So editors don't really know these issues. They don't know how to assign these stories. And we just stigmatize elder care in a detrimental way. So yeah, I'm hoping that more people will catch on and start writing about elder issues, but we're fighting the good fight, the few of us who are doing it.
Is it time for one more question? I know that we're kind of
Always,
over there.
many more.
Okay.
Keep going.
So so my mom was in assisted living until about a week or two after the COVID restrictions. I could no longer see her every day. She couldn't go down to the dining room to have meals with her friends. She started going stir crazy and she fell 5 times in 4 days.
Mm.
So she ended up in a nursing home. So she's been there for 2 years. It's a fabulous nursing home. She's private pay. It also is mostly a short-term rehab center. So it's mostly short-term skilled, you know, for rehab. Have you seen any difference in the type of care in a facility like that as opposed to strictly long-term? I initially thought that it was a really good thing until she started declining. And I still go every day now that I can. So for the last year, I've been going every day. And I'm super,
No, I'm so
I
sorry.
started, you know, so I've been a hospice nurse and I'm currently a hospice chaplain. I know what hospice is. Okay. She has dementia. And my thought always was, at what point do I call work for an eval?
Mm.
Because she's getting all the care that she needs. I can get support from my coworkers, whether she's on hospice or not.
Mm.
But when I started seeing her decline and I mentioned it to staff, I was completely shot down.
Yeah.
And they were seeing my mom as they had seen my mom for the last 2 years. And I think that disconnect is what really broke my heart.
Mm-hmm.
Now, she is on hospice. She qualified. The nurse was with her, and within the first 5 minutes, she's like, "Oh yeah, she qualifies." And I knew that.
Yeah.
But it was very hard for me as someone who has worked in hospice for several years and as a daughter to see these changes and have people outright, the nurses out and CNAs outright tell me that I was wrong.
Right. I didn't catch your name.
Susan, so sorry, Susan Hillman.
Susan, don't apologize. I'm so sorry. This is the hardest thing to do. I just want to send you strength. I think it's not just nursing facilities, right? This hospice is a 6 months program. So, you know, if you have 6 months or less to live, you qualify for hospice. And yet the average stay at the moment is, you know, it's like 7 days or something, right? So we know that people aren't sending patients. We know that facilities, that doctors, that the medical profession is not sending elders, it's not sending people to hospice. We're underutilizing hospice. But I do think that a lot of it is that they want to encourage you and tell you that your mother's going to be fine. They want to deny that she's declining. They are in the business of care, and it's very hard when that care isn't curative anymore to make the switch to make it comfort. Yeah. So I think that's part of the problem. I think we're just reticent to send patients to hospice because it feels like giving up, and all of those other, you know, you guys are hospice folks, you know the whole drill, right? Like,
Yeah,
we just don't send people.
Right. And do you think that it's more so that way in a facility that primarily does short-term rehab?
Well, the other thing is a bed in a nursing facility is long-term and short-term. The distinction is made by the facility, and it is made to maximize profit. There's actually a subcategory of accountants that advise on how to maximize Medicare payments in facilities. So the designation, you'll find facilities where it's long-term care upstairs and short-term care downstairs. The facility decided that if you are in a bed and your Medicare runs out and they say, okay, you've got to leave because you have no more Medicare, that's not true. If you have a bed in a facility, they cannot evict you. They are required by law to help you file paperwork for Medicaid. So any bed in these facilities is most likely coded to both
Okay.
short-term and long-term. And that is something you should talk to your ombuds person about, because they'll be able to tell you exactly what's going on with that bed. But if you have a loved one in a bed and you want them to stay in that bed, don't leave it. If the facility tries to kick you out, they can't. You're in a different situation. She's happy there, but
Yeah.
you would, so she has hospice in the facility?
Yeah.
Okay, I'm so sorry.
Thank you. Thank you.
It's a hard.
It was heartbreaking, but it also was a major relief because I went from me feeling like I had to police everything being a nurse.
Right.
You know, it's like, so
Yeah.
I went from feeling like I couldn't be the daughter because I had to be the hospice nurse / hospice chaplain. So she's been on our service for about 5 weeks now. So I've gone from that to I see something and I call work.
Yeah.
You know, it's
Yeah.
like I don't have to be the middle person anymore.
No,
and I
you've got
can-
help now. Yeah. Yeah. Well, I hope that her days are comfortable and that yours are as well. Yeah.
I appreciate that.
I'm glad you
Thank-
spoke up.
And I think, Susan, you raised a good point for all of us, is that it's what families reflect to us oftentimes is, yes, I know I have certain rights and I know that I can advocate for my loved one. And it's what Kevin said before about bringing the coffee to the caregivers, is that you don't want to anger the very folks that you're going to leave your loved one with and go home for fear of how they might be treated. It's that feeling of absolute vulnerability. And that can be really difficult to assert oneself. And that's why the ombudsman, that's why having more oversight, having more ability, so it's not up to the family to be the ones that are making these demands.
Absolutely. Absolutely, David. The ombuds person can often be the heavy, right? They can be the ones who understand all of the personalities, and they can do that work. I imagine that hospice as well can do that, whether it's the hospice nurse or the hospice doctor that's coming into the facility, that they might be helpful as well. I do think that residents are very much afraid of retaliation. I do think that their entire comfort is dependent on the people around them. And quite often these are people who are working, who are overworked and undertrained and underpaid. So it's just a bad situation all around.
And I think that it's that whole ecosystem that you talked about too, is that hospices in some ways are afraid of making too many waves, because then they won't get referrals from that
Right.
facility moving forward.
Totally.
And so again, it comes back into the payer sources, and it needs to be somebody that has some teeth and oversight that's outside of that payer system for it to be mostly effective.
Yeah. What great questions. What else did we cover? We're just getting started. We have so much more. But for the moment, is there any other outstanding question. You're all wonderful. It's been a pleasure to be here tonight.
Thank you so much, Ann. It was a great conversation. And like you said, we could go in a lot of different directions. And so maybe we're going to have you back to do that again at a later time. But thank everyone here who participated in the conversation. You expanded this conversation so much. And we want to invite you back next month. On May 19th, we have Carla Sutter, who is with Healthcare Directives Registry at Health Current. Her talk is entitled "Dividing Non-Titled Property Without Dividing Families." It's going to be a conversation about how difficult it can be when families are most stressed after the death of a loved one. The seminar will help attendees learn how the family can prepare to pass on personal property without causing a family divide. So if you would like to take part in that, you just go to our website, rootsandroads.org, and you'll see an easy way to register for that. And then in June, we have Martha Lundgren, who's the board president of the Funeral Consumers Alliance of Arizona. She will be offering a presentation because everybody dies. It's really going to be about helping folks understand how to arrange affordable, dignified, meaningful care for someone who has died, and avoiding some of the pitfalls and difficulties. The session's designed to help people make well-informed economical decisions about what you must purchase and what's optional when arranging for burial, cremation, or other after-death care. So please join us for both of those. If you find these presentations helpful and meaningful, please consider making a donation to Roots and Roads. It goes to allowing us to be able to provide this kind of education to the community for free, and also goes to help patients and their loved ones with the patient fund request that we talked about earlier. So thank you all so much. We hope you have a wonderful evening and that you can enjoy some of this beautiful spring weather, whether you're in New York. We're so sorry that we had to keep Ann up well past her bedtime. We're so grateful that she joined us, but we look forward to seeing you again very soon.
Bye, everybody.
Bye, everybody.
Thank you.
Thank you.